Good morning, ladies and gentlemen. So today I'm going to restart my lecture from the place where I left the last week's lecture. So we were discussing the different principles of topical therapy. So this lecture is part 2 and the end part of this topic, that is the topical therapy that is used in dermatology practice. So the first topic we are going to discuss today is the topical glucocorticoids, a very important topic. And you all know that glucocorticoids is the cornerstone of the dermatological treatment world over. And a good dermatologist knows where and when to use the right glucocorticoid. It is generally referred to as topical corticosteroid and have been used for treating skin diseases since 1952. In addition to the mainstay of treatment in eczematous dermatosis, they are used in management of most inflammatory skin conditions. In view of the great difference in potency between different corticosteroids, it is essential for the dermatologist to be able to classify them by potency in order to predict the response and possible adverse effects. So, using the right corticosteroid for the right indication for the right person at the right site is what the dermatology training and practice is all about. To compare the potencies of topical corticosteroids, the most widely used approach is the vasoconstrictor assay, which depends upon the vasoconstricting properties of glucocorticoids. More a glucocorticoid causes vasoconstriction, more potent it would be. The degree of pallor produced following an application of a compound to the skin seems to correlate fairly well with the clinical potency. So more pallor, more potent. The British National Formulary employs a 4-category scale: mild, moderate, potent, and very potent. In USA, the topical corticosteroids are ranked using a scale ranging from class 1, which is super potent, to class 7, which is mild. But we are today following the British National Formulary classification. Class 1 is a very potent corticosteroid, and the prototype drug in very potent is clobetasol propionate, which is available with different trade names like Dermovate, Clobivate, Clobiderm, etc. Then class 2 is potent corticosteroids. Among the potent corticosteroid is the beclomethasone dipropionate, betamethasone valerate, betamethasone dipropionate, betamethasone valerate 0.1%, betamethasone dipropionate, diflucortolone, fluocinolone, hydrocortisone butyrate, mometasone, triamcinolone acetonide. So the potent corticosteroids are available with different brand names like Provate, like Senelar. Then these are the Moment, Highweight, Adventon. So these Moment, Adventon, these are potent corticosteroids, but they are prepared in such a way that their effect or adverse effect on the skin are very minimal. That's why they can be used on facial skin. Then comes the moderate potency corticosteroids. These are classified as class 3. Among these, the main is betamethasone valerate 0.025%, which is Retinoids. In addition, there is fluocinolone and flucortolone. Among the mild corticosteroids is the hydrocortisone and fluocinolone. we usually employ 1% hydrocortisone as a mild corticosteroid. Indications. Corticosteroids are anti-inflammatory, they are immunosuppressants and anti-proliferative, and hence they find numerous applications in dermatology. Mechanism of action. Corticosteroids diffuse through the stratum corneum barrier to reach the cytoplasm of keratinocytes and other cells present in the epidermis and then reach the dermis. Clinical potency of corticosteroids seems to be strongly related to the receptor binding affinity. These interactions lead to suppression of production of cytokines, inhibition of T cell activation, changes in function of endothelial cells, granulocytes, mast cells, and fibroblasts, and inhibition of proliferation of all these cells. Part of the anti-inflammatory activity of corticosteroids may be explained by their ability to induce the synthesis of lipocortin. This enzyme affects the production of arachidonic acid, the precursors of leukotrienes and prostaglandins. Side effects. The side effects of corticosteroids are directly related to their potency. The more potent a steroid is, more chances of giving side effects. Local side effects. The most worrying is the cutaneous atrophy, since this may become permanent. Fragility and stria distensi may develop. The loss of connective tissue support for the dermal vasculature leads to erythema, telangiectasias, and purpura. Other problems include the development of contact allergy and risk of promoting infection. There are the additional risk of inducing acneiform eruptions. Inhibition of melanocyte function may develop, giving rise to a localized hypopigmentation. This is the logic of including steroids among the whitening creams, which are not, of course, allowed, but many vendors put them to make their cream more efficacious. So the main local side effects are the cutaneous atrophy, loss of collagen around the vessels leading to telangiectasias, erythemas, which is almost permanent, and purpura. Purpura can occur easily without much trauma. Then certain steroids in specific conditions can cause cutaneous allergies, and because they promote infection, so if they are used in wrong places, then they can promote infection and cause acneiform eruption and temporary or permanent hypopigmentation. Even the mild corticosteroids, such as hydrocortisone, have been shown to inhibit the collagen synthesis. In general, potent corticosteroids should be used only on the face when treating a recalcitrant dermatosis, such as chronic discoid lupus erythematosus. It is advisable to avoid use of topical corticosteroids in presence of active viral infections like herpes simplex, viral wart, molluscum contagiosum, in fungal infections, and in scabies. Nodular granulomatous candidosis or infantile gluteal granuloma is found only in infants, which present as intratriginous candidiasis and are treated with steroids, hence resulting in these granulomas. Use of topical corticosteroids on face result in development or exacerbation of rosacea, perioral and periocular dermatitis. One side effect which is missed, I think, is induction of hair production. So if these steroids are used on the face, it will also result in hirsutism or iatrogenic hirsutism. Then use of corticosteroid eye drops is known to raise intraocular pressure, increase the risk of cataract formation, and aggravating intraocular infections, especially herpes simplex. Glaucoma also result in inadvertent use of corticosteroids eye drop. Wound healing and reepithelialization has been shown to be impaired by locally applied corticosteroids. Systemic effects. Inhibition of pituitary adrenal axis by excessive application of moderately potent topical corticosteroids is well documented. Hence, it is recommended that patients should not use more than 50 grams of super potent or 100 grams of potent corticosteroid per week. Children and babies have high ratio of surface area to body volume and are more vulnerable to pituitary adrenal suppression. So Cushingoid features may be seen in infants if they are inappropriately treated. So presence of Cushing syndrome is more common in infants compared to adults. So if an adult is using more than 50 grams of dermovate or clovivate per week, then there are chances of getting Cushing syndrome or iatrogenic Cushing syndrome. Tachyphylaxis and rebound phenomena. It is common for patients to report that a topical corticosteroid, which was highly effective during the first few days of application, has subsequently lost its efficacy. On occasions, withdrawal of corticosteroids is followed by flare of the disease. So decrease in efficacy of a corticosteroids after a prolonged use is called as the tachyphylaxis, while the flare of the disease after sudden withdrawal of corticosteroid is called as the rebound phenomena. In severe cases, withdrawal of treatment with potent or very potent corticosteroids is followed by eruption of severe generalized pustular psoriasis. Vehicles and formulations. Ointments, steroid ointments are helpful when eczema is dry, while creams are more effective if eruption is moist or exudative. Steroid lotions, gel or mousses, and shampoos are useful for the scalp. In case of lichen simplex chronicus or prurigo, the use of steroid-impregnated tape will prevent scratching and increase drug penetration by effective occlusion. Several antimicrobial agents are commercially formulated in combination with topical steroids that include glycanol, clotrimazole, fusidic acid, miconazole, neomycin, and nystatin. So all these antimicrobials are available in different with different corticosteroid preparations. It can be helpful when there is a clear indication for each constituent, but the approach of covering all possibilities is not recommended. So generally, antibiotic containing corticosteroid preparations are given for such indications where it is deemed necessary to treat an inflammatory dermatosis which is already infected or there are chances of getting infection. Corticosteroids are also combined with tars, salicylic acid, or calcipetrol, and it is useful in treatment of psoriasis with clear-cut indications. The stability of steroid in a novel formulation is unpredictable, and changes in vehicles may alter the level of steroid penetration into the skin as well as the systemic absorption. So all these factors need to be considered while prescribing a corticosteroid. Judicious use of occlusion is an invaluable strategy in management of pemphigus, refractory plaque of psoriasis on the leg, or a patch of lichen simplex. So the occlusion should be judicious and not done unnecessarily for a prolonged period of time, because that will result in all the local side effects. Intralesional steroids. The recalcitrant dermatosis, for example, alopecia areata, keloidal scars, lichen simplex, nodular prurigo, and hypertrophic lichen planus, may respond to injection of steroids into the lesions. Triamcinolone is often used, but dermal atrophy and leukoderma may occur. So it is advisable to use a low concentration, that is 10 milligram per ml of triamcinolone for all such intralesional use. Calcineurin inhibitors. This is again a very commonly used preparation nowadays. Topical formulation of tacrolimus or pimecrolimus have been developed for the topical treatment of atopic eczema. The mechanism of action is similar to that of cyclosporin. Lymphocyte activation is suppressed by inhibition of calcineurin, a calcium and calmodulin dependent serine threonine phosphate. A notable advantage of these agents is that they do not induce cutaneous atrophy, even with long-term regular application. Hence, it is therefore possible to apply them to facial and flexural areas. The efficacy of 0.1% topical tacrolimus in atopic eczema have been demonstrated to be comparable with efficacy to potent topical corticosteroids. The most frequently encountered side effect is a burning sensation lasting for a few minutes after application. It is therefore unlikely that topical application of tacrolimus will have systemic activity. So they are safe drugs to be used. Do not cause cutaneous atrophy, do not have systemic toxicity, but there is a common complaint of burning sensations after application. And this sensation may last for a few minutes. Tacrolimus does not appear to penetrate sufficiently to be effective in chronic plaque psoriasis. So these are not a useful drug for psoriasis. However, they are useful for all kinds of eczemas and even alopecia areata. But having said that, for facial and intracutaneous psoriasis, where the lesions are not much indurated, tacrolimus can be tried. Pimecrolimus is a macrolactam similar in molecular structure to tacrolimus, compared with which it is more lipophilic but less potent. When used in atopic eczema, pimecrolimus effectively inhibit the flare of disease and reduce the requirement of topical corticosteroid. This is, by the way, not available in Pakistan, but tacrolimus is freely available with different brand names. Cyclosporin. High molecular weight cyclosporin and its consequent poor penetration through stratum corneum probably explains why the topical preparations have not been found to be effective for skin diseases. Mucous membrane present less of a barrier, and ophthalmic formulation of cyclosporin have been used successfully for ocular rosacea and atopic keratoconjunctivitis. So having said that, cyclosporin is not effective as topical formulation over the skin. However, the cyclosporin containing eye drops are useful in rosacea, ocular rosacea, and in atopic keratoconjunctivitis. Then comes a very important drug, that is retinoid. The retinoids can be defined as a compound that are able to interact with retinoid receptors. Topical retinoic acids have been used in treatment of acne vulgaris for over 3 decades. Retinoids are used for many indications so these indications are relatively new, and these indications include for psoriasis, in photoaging, and numerous disorder of keratinization, as well as for the suppression of dysplasias and malignancies. So cutaneous and superficial malignant disorders like actinic keratosis, superficial spreading BCC, they are also effectively treated by retinoids. Retinoid receptors are mainly active as the heterodimers of RXR and RAR. RXRs can also be dimerized with several other similar receptors, such as vitamin D receptors, the thyroid receptors, and the orphan receptors. The end result of these processes acting on numerous different genes is that retinoids demonstrate a tendency to normalize the keratinocyte differentiation in diverse circumstances where this is disturbed. Metabolism of retinoids can take place within the keratinocytes. Systemic exposure to retinoids applied topically seems to be minimal. Nonetheless, it is generally recommended that even the topical use of retinoids should be avoided during pregnancy. The synthetic retinoids currently used in topical treatment of skin diseases are adapalene, bexarotene, and tazarotene. All these compounds are effectively absorbed into the epidermis when applied topically. Retinol, the age-old retinoid. Retinol, vitamin A, is used widely in cosmetic products and tend to be regarded as a vitamin supplement rather than medicament in this context. However, it is clear the retinol applied topically to the skin is absorbed into the epidermis and exhibit many of the pharmacological properties of the retinoic acid. So even if it is marketed as a vitamin preparation, it will have the effects of the retinoic acids. Then retinoic acid. Retinoic acid, also known as tretinoin, also known as the tretinoin, is well absorbed into the skin when applied topically and exerts potent local effects on the cellular metabolism. Retinoic acid is used in the treatment of acne vulgaris, particularly the comedonal acne. Topical retinoic acid improves several features of photoaging that includes fine lines and coarse wrinkles. And tretinoin is both therapeutic and prophylactic effect on chemically induced skin tumors, may be used to treat small actinic keratosis in combination with 5% 5-fluorouracil cream. The retinoic acid can help to reduce various forms of hyperpigmentation and for a wide range of conditions like senile comedons, comedo nevus, plain warts, reactive perforating collagenoses, and localized mild diarrhea disease. So combination of retinoids in cutaneous whitening creams have been used since ages as it itself causes hypopigmentation and is also used as exfoliant and keratolytic and used in indications like in comedons and plain warts. They are also used in keratosis pilaris, in lamellar ichthysis, ichthysis vulgaris, erythrokeratoderma, oral lichen planus, Fox-Fordyce disease, and hypertrophic scars and keloids. Topical application of retinoic acid has not found a role in treatment of psoriasis. Isotretinoin. Isotretinoin is 13-cis-retinoic acid, is readily isomerized to tretinoin and vice versa. It is used both topically and systemically for the treatment of acne vulgaris. When used topically, it is considered somewhat less irritant than tretinoin, but may be more irritant than adapalene. Topical isotretinoin work mainly by inhibiting comitogenesis and reduce sebum secretion. Like tretinoin, it is advocated for treatment of photoaging and actinic keratosis. L-tretinoin. A 0.1% gel preparation of L-tretinoin is used systemically for chronic hand dermatitis and being investigated as a treatment for HIV-related Kaposi sarcoma. So the main indication of L-tretinoin is the hand eczema. Then comes the adapalene. It is a synthetic retinoid used for treatment of acne vulgaris. It appears to retain the comedolytic activity while showing less potency for irritancy than with retinoic acids. Bexarotene. Bexarotene is a novel synthetic retinoid with specific activity for RXR with its rexinoid receptors. In addition to its systemic use for cutaneous T-cell lymphoma, it is available as 1% gel for early plaque stage of mycosis fungoides, with complete or partial response observed in 21% and 42% of patients, respectively. So in early plaque psoriasis, bexarotene topically is very effective. Then comes tazarotene. Tazarotene is a synthetic retinoid that exhibits a degree of receptor specificity with RAR receptors, alpha, beta, and gamma. It was developed mainly for the treatment of psoriasis, and acne vulgaris is available in gel and cream formulation and a concentration of 0.1 and 0.5%. In psoriasis, 65% of the patients show 50% or greater improvement at 12 weeks, but its value is limited by its irritancy. Improvement of nail psoriasis has also been reported. Vitamin D analogues, also known as the deltanoids or secosteroids. The therapeutic potential or vitamin D in psoriasis have been recognized for many years. Topical use, however, permits considerable efficacy with wide safety margin. Calcipotriol was first of a number of vitamin D analogues to be developed and evaluated for treating psoriasis. The vitamin D receptor is the phosphopeptide, is a member of steroid receptor superfamily, being similar in structure to the retinoid thyroid hormone T3 receptor. The therapeutic action of secosteroid appears to result from a potent anti-proliferative effect and the ability to promote differentiation. They may perhaps also have an immunosuppressive action. They lead to interleukin-2 lymphocyte activation and release of interleukin-8 and interleukin-10. All the analogues currently used in treatment of psoriasis are 1-alpha hydroxylated compounds, potentially causing hypercalcemia in overdose. So vitamin D analogues have the advantage that they are more cosmetically acceptable than tar and ditronol, and in contrast with topical corticosteroid, do not cause cutaneous atrophy. Tacalcitrol. Once daily application of tacalcitrol 4 microgram per gram is less effective than twice daily calcipotriol at 50 microgram per gram and is less irritant too. It is therefore useful for treating facial and flexural psoriasis. Then calcitriol. Calcitriol have been widely used topically at various concentrations that range from 0.3 to 15 microgram per gram. When applied twice a day at a concentration of 3 microgram per gram, controlled trials have demonstrated the degree of efficacy can be maintained with minimum risk of effect of calcium homeostasis. Calcipotriol. Although developed relatively recently, calcipotriol or calcipotriene has now been more intensively investigated. It is ideal for topical administration and can be safely used in higher concentration than calcitrol or tacalcitol. Although topical calcipotriol may benefit generalized pustular psoriasis and erythrodermic psoriasis, absorption of drug may be sufficiently increased and careful monitoring is required. Combination with moderately potent or potent topical corticosteroids preparation may increase the efficacy and reduce the irritation. This increased efficacy of once daily application relative to twice daily calcipotriol alone. So if a combination cream is used, then we can advise that cream for once daily application rather than twice daily. The maximum recommended dose of calcipotriol is 100 grams of ointment per week. Exceeding this dose induces hypercalcemia, although serious harms appear to be unlikely. Other indications of topical vitamin D preparations are the confluent and reticulate papillomatosis, disseminated superficial actinic porokeratosis, extragenital lichen sclerosis, Grover's disease, lichen amyloidosis, lichen planus, nodular prurigo, morphia, PRP, Ritter syndrome, vitiligo, and epidermolytic palmoplantar keratoderma. Calcipotriol has not proved beneficial in trials for actinic keratosis, in alopecia totalis, in Darier's disease, in hereditary palmoplantar keratoderma, in keratosis pilaris or seborrheic dermatitis. Maxacalcitol is another analog with efficacy in psoriasis similar to calcipotriol. Not available here, although. Cytotoxic and antineoplastic agents. The first agent to be discussed here is 5-fluorouracil. This pyrimidine analog is anti-metabolite that inhibits pyrimidine metabolism and DNA synthesis. In form of a 5% cream, 5-fluorouracil or 5-FU is very effective treatment for actinic keratosis and for selected patients with Bowen's disease and superficial basal cell carcinoma. One more indication to be added is porokeratosis. A commonly used regimen comprises of twice daily application for 2 weeks. A brisk inflammatory response should, however, occur within the keratosis, otherwise clearing is likely to be incomplete. So inflammatory response is a positive thing. Combination with potent topical corticosteroid have been shown to limit the intensity of inflammatory response without reducing efficacy. So if 5-fluorouracil is combined with a topical corticosteroid, then the inflammatory response is less, although the effect of 5-fluorouracil will be there. 5-FU have been advocated for a range of other indications that include actinic cheilitis, labial keratosis, genital warts, both in female and male, under adhesive plaster for common wart, extramammary Paget's disease, Darier's disease, and superficial actinic porokeratosis. Systemic toxicity including abdominal pain, fever, diarrhea, mucositis and myelosuppression is reported from topical application of 5-FU in patient with very low activity of enzyme dihydropyrimidine dehydrogenase. So this is a rare occurrence, but this should be known to everyone. 5-fluorouracil injection diluted with triamcinolone has found its place in treatment of keloid nowadays as an intralesional injection. Bleomycin. Bleomycin is a cytotoxic agent with anti-tumor, antibacterial, antiviral activity. It binds to DNA, causing strand secession and elimination of pyrimidine and purine bases. It has been used intralesionally for treatment of recalcitrant viral wart for over 3 decades and result in 75 to 95% clearance of hand wart and 60% plantar wart following 1 to 3 injections of 0.1% bleomycin. So whenever you are planning to use intralesional bleomycin for a difficult to treat wart, please do read the dilution instruction from the internet so that you may not inject less diluted bleomycin, which can cause systemic side effects. Bleomycin have been used to treat for oral leukoplakia as 1% solution in DMSO, applied for 5 minutes daily for 14 consecutive days. A small volume do not cause systemic toxicity, but local pain is significant. And I second that this is a very significant side effect of injection bleomycin. That is the local pain. Diclofenac. Diclofenac is a non-steroidal anti-inflammatory drug that has been developed in a gel formulation containing 3% diclofenac and 2.5% hyaluronic acid for the treatment of actinic keratosis. The mechanism of action proposed that inhibition of cyclooxygenase may be involved, and an open label study in which gel is applied twice daily for 30 to 90 days, the treatment seemed to be well tolerated, though pruritus is occasionally seen. Imiquimod. Imiquimod is imidazoquinolone that interact with toll-like receptor 7 or TLR7, a cell surface receptor found on cells of monocyte lineage, which in turn promote the development of antigen-specific cell-mediated immune response. The first clinical application was for the treatment of genital warts. Imiquimod 5% cream 3 times weekly for 16 weeks produced complete clearance in half of the patients. Long-lasting or therapy-resistant common warts, molluscums, and stucokeratosis have also reported to respond. 84% of actinic keratosis clear in one trial, partial or complete response in superficial BCC, cervical, vaginal, or vulval intraepithelial neoplasms, and bovinoid papillosis, Paget's disease, porokeratosis of Mibili. It can be given in lentigo maligna in frail elderly where surgery is impracticable. Ingenol mebutate. Ingenol mebutate. The novel compound is effective new approach for treatment of actinic keratosis and has advantage of very rapid action. It promotes induction of cell necrosis, disruption of mitochondria, brisk and a tumor-specific immune response. Recommended regimen is daily application of 0.5% gel for 2 days for lesions on trunk and limb, and 0.15% gel for 3 days for lesions on scalp and face, with reported clearance of 34% and 42%. Mechlorothamine. Mustine or nitrogen mustard is a cytotoxic drug that is highly active when applied topically Immediate hypersensitivity reaction can also occur but are less common. Most frequent use is in a treatment of CTCL with T1 or T2 stage. Used most frequently as 0.1 or 0.01 or 0.02% preparation, and it is applied once a day. It is highly effective and seems to be well tolerated in children with Langerhans cell histiocytosis. Its use in psoriasis is now of historical interest now, as nobody uses it anymore. There is some success in its use in alopecia totalis and in pyoderma gangrenosum. Methotrexate topically, used in psoriasis and generally been superior to placebo. The treatment is well tolerated, however, has not gained very popularity. Then T4 endonuclease 5 is a bacterial DNA repair enzyme that excises the damaged section of DNA. When used for an year in patients with xeroderma pigmentosa, there is reduced occurrence of neoplasm. So T4 endonuclease 5 is now an emerging treatment, topical treatment for prevention of tumors in xeroderma pigmentosa. Depigmenting agent, a popular topic for a dermatologist in Pakistan. Hydroquinones. Hydroquinones is widely used as depigmenting agents both in clinical and cosmetic context. They reduce pigmentation as a result of inhibition of melanin synthesis, since it is known to inhibit the tyrosinase enzyme. In African population, use of hydroquinone extensively as skin lightening agent is strongly associated with exogenous ochronosis. The concentration of hydroquinones in cosmetic products has been legally restricted to 2% with aim of reducing the risk of ochronosis. But definitely ochronosis or exogenous ochronosis occur by very prolonged and very extensive use of hydroquinones. Monobenzyl ether of hydroquinone. Skin bleaching with 20% monobenzyl ether of hydroquinone, also known as the monobenzone, is a generally reserved for treatment of carefully selected cases of vitiligo, where there is increased pigmentation, or the body is trying to make melanin in patients who are completely decolored. The resulting depigmentation may be permanent and irregular. The resulting depigmentation due to monobenzyl ether of hydroquinone. So treatment may need to be prolonged and is not always successful. So monobenzyl ether of hydroquinone has no place for use as cosmetic chemical or cosmetic product. Contact dermatitis can develop and may cause corneal and conjunctival pigmentation. The phenol derivatives, mecunol or 4-hydroxyanisole or 4-methoxyphenol is another phenol derivative with depigmenting properties. It is constituent of commercially formulated solution, 2% mecunol or 0.1% retinoic acid, marketed for treatment of solar lentiginosis. This combination appeared to be more effective than either constituent use alone. Mecunol 20% cream is successfully used to remove the residual pigmentation in severe vitiligo. Retinoic acids, retinoin already discussed, is successfully used to reduce pigmentation in variety of disorders like melasma, actinic lentiginosis, post-inflammatory hyperpigmentation. The mechanism of action is by reduction of melanogenesis consequently upon the reduction of tyrosinase activity. Kligman cream. The Klickman formula comprises of 5% hydroquinone, 0.1% retinoid, and 0.1% dexamethasone in hydrophilic ointment. It is widely used as a depigmenting treatment for resistant melasma. The combined formulation is considered more effective than any of the individual constituents. Azelaic acid. As a depigmenting agent, it is moderately effective in treatment of melasma. The proposed mechanism is direct or indirect inhibition of tyrosinase. 20% azelaic acid cream prove equivalent to efficacy of 4% hydroquinone cream. Azelaic acid 20% cream is effective in treatment of acne vulgaris and rosacea. This is likely to be due to combination of antimicrobial and anti-inflammatory properties. Azelaic acid also has an antineoplastic properties, inhibiting mitochondrial function and DNA synthesis, and has been used as a palliative treatment of lentigo maligna and melanoma. Kojic acid. This is a fungal metabolite known to inhibit tyrosinase. In treatment of melasma, 1% kojic acid proved to be equal in efficacy as 2% hydroquinone. Then lecithin. This compound, which can be extracted from licorice and other herbal sources, has been reported to be effective in reducing pigmentation in melasma. Depilatories. Depilatories are defined as preparation causing temporary removal of hairs, while the appellation denotes permanent destruction of the follicles. Depilation can be achieved by shaving, waxing, plucking, threading, and use of topical depilatory creams. Systemic androgen antagonists have a role to play in some cases. Traditional depilatory creams depend upon breaking the disulfide bonds in the hair. 3 main classes are currently used. The oldest and various sulfides, for example, 20% strontium or barium sulfide, which has an unpleasant odor. They are effective on terminal hairs in eczema. Thioglycolates are being used more frequently but are slower to work. Concentration of 2.4 to 4% is effective in 5 to 15 minutes. Substituted mercaptans or thioalcohols are most widely used. They work slowly but are suitable for use on the face. Eflornithine hydrochloride is an irreversible inhibitor of ornithine decarboxylase, an enzyme required for hair growth. It is marketed as 13.9% cream that can slow the growth of facial hairs. So it is effective if combined with other depilatory procedures as well as with hair removal lasers. Sensitizing agents. These chemicals include dinitrochlorobenzene, DNCB, squaric acid, and diphencyprone. Almost every individual will develop an allergic dermatitis after repeated contact with these substances on the skin, and hence manipulate the immune response to advantage in a wide range of benign and malignant skin diseases. It downregulates the autoimmune reaction responsible for alopecia with increased production of interleukin-10. Currently, topical sensitizers have found 2 main roles in dermatology, for alopecia areata and for the viral warts. Then a very important and pertinent topic of today is the sunscreens. However, individuals with white skins are clearly at greater risk for melanoma, and non-melanoma skin cancers, as well as photoaging. Sunscreen, if applied correctly, reduce UV penetration in the skin and prevent the occurrence of both melanoma and non-melanoma skin cancers. The ideal sunscreen should block completely the transmission of both UVB, which is available at a wavelength of 280 to 320 nanometer, and UVA that is available in a wavelength of 320 to 400 nanometer, while at the same time cosmetically acceptable, pleasant to use, and durability on the skin that is effective for a long period of time, including photo stability and water resistance. So these are all the traits of an ideal sunscreen. Sunscreens are generally more effective in blocking UVB than UVA. So UVA exposure is significant contribution to carcinogenesis, to photoaging, and play a central role in photodermatosis like polymorphic light eruption. Sunscreen falls in two broad categories: the physical sunscreen that act by reflecting and scattering ultraviolet light, and chemical agents that absorb the ultraviolet light. Physical agents are titanium dioxide and zinc oxide that block a broad spectrum of UVB, UVA, and visible light. Their efficacy against UVA and visible light depends on the particle size. Large particle size result in superior efficacy but reduce cosmetic acceptability due to increased whitening of the skin, as we see in the cricketers. Chemical agents vary in their absorption of UV radiation, some blocking predominantly UVB while other blocking UVA as well. Butyl methoxy dibenzylomethane has an absorption spectrum of 320 to 400 nanometer, and terephthalidine dicamphor sulfonic acid has a absorption spectrum that extends from UVB and ends by UVA, that is 390 to 400 nanometer. Sunscreens contain compounds, agents that may cause irritation, allergic, phototoxic, or photoallergic reactions. Benzophenones are probably the commonest sensitizers, while dibenzomethane or para-aminobenzoic acid and cinnamate may also cause photoallergic dermatitis. Sun protecting factor was introduced to help consumer evaluate the level of protection of UVB in risk of sunburn. The sun protecting factor is equal to dose of UVB radiation producing minimal erythema with a sunscreen. It is generally accepted that thickness of sunscreen applied on which SPF calculation is normally and usually taken, and that is around 0.5 milligram of sunscreen per centimeter square, which is quite a thick coat. There have been some debate that increasing SPF beyond 50 provide any additional benefit or not. Sunscreens have been used to reduce UV-induced immunosuppression, which is considered to play a role in cutaneous carcinogenesis like actinic keratosis and BCC. While the risk of melanoma is reduced by use of sunscreen, is also a very difficult question to answer. In addition to protection of healthy skin, sunscreen have an important role in management of patients with photodermatosis. The commonest of these is polymorphic light eruption. Less common is actinic prurigo, chronic actinic dermatitis, hydrua vacciniforme, lupus erythematosus, porphyria, and solar urticarias. Tars. Tars are derived from wood, shale, and especially coal, and used in topical treatment of skin diseases for millennium. Wool tars. Oil of cedar or juniper, beech, birch, or pine have been used in treating eczema and psoriasis. Oil of cane is particularly used in scalp preparation. They have normally been applied with 1 to 10% strength in various formulations. That includes ointments, paste, paints, as well as shampoo. So oil of cane is mainly used for the scalp. Then shale tars. Ichthyol is a shale tar. It contains high portion of organic sulfur. Shale tar is antiseptic and anti-inflammatory and useful in management of eczematous dermatosis and as paste bandage in treating eczema, atopic eczema. Coal tar is black, viscous fluid with potent characteristic smell. Coal tar is still used in treatment of psoriasis as a basis of Ciclosporin regimen, combining tar with UVB. The disadvantage of coal tar include potency for irritancy, phototoxicity from both UVA and visible light, and occasional allergic sensitization. A cytostatic effect of crude coal tar have been accepted. Over the years, a wide range of more acceptable formulations of tar have been developed, such as creams, ointment, paste, bath additives, shampoos, with view to improve acceptability. So many soaps and shampoos of tar are currently available in market. Antihistamines. Topical antihistamines like diphenhydramine, meframine, maleate, promethazine is widely used as an antipruritic agent. The efficacy is questionable. Marked potential to sensitize, which has led a trend to deter the dermatologists from advocating them as antipruritic agents. Antiperspirants. Most antiperspirant marketed for cosmetic purpose contain aluminum chloride hexahydrate. In contemporary products, chlorohydrate or aluminum zirconium complexes are also used. Cosmetic antiperspirants often combined with antimicrobial agents that reduce axillary odor by inhibiting the action of bacterial metabolism on various components of apocrine sweat. In treatment, higher concentration of aluminum chloride hexahydrate, 20 to 25% in ethanol are generally used. Blockade of sweat duct is regarded as the principal mechanism of action. So most of the deodorants that are available over the counter are antimicrobial, antiperspirants. And of course, they are helpful in reducing the odor. Traditional remedies that have fallen out of favor include the aldehydes. They work by similar action as aluminum salt. Aqueous glutaldehyde solution up to 10% is applied as swabs on sole of the foot. Formaldehyde solution 1 to 3% used as twice daily. Soaks is helpful in some cases, but this compound is a sensitizer and not ideal for prolonged use, but can be effectively used with iontophoresis. Anticholinergic agents applied topically are also effective. Poldine, metasulfate, and glycopyrronium bromide are effective. Glycopyrrolate cream 2% or lotion is used with success in patients suffering from gustatory sweating. Surgical treatment and injection of botulinum toxin is another option to reduce sweating both in axillae and on palm and soles. Traditional remedies. They include various dyes like gentian violet. It is a triphenyl methane dye with antiseptic properties against bacteria and yeast, employed since years as topical treatment of bacterial and fungal skin infections. No report of human malignancy. Licensed as 0.5% aqueous solution to unbroken skin, but not recommended for mucous membrane or open wounds. The brilliant green. This is also a triphenyl methane dye and has a property similar to gentian violet. Magenta. Magenta paint. It is a basic fusin, an active component of Castellani paint, also contain acetone, boric acid, ethanol, phenol, resorcinol, and water. It is known to have activity against gram-positive bacteria and fungi, but is no longer used because of potential carcinogenicity. Eosin is a red dye and has an astringent and antiseptic properties. Was used as 2% solution to reduce inflammation in severe inflammatory dermatosis, in particular erythrodermic psoriasis, but no longer used now. Other traditional remedies include camphor, is best known as the moth repellent, sometimes added to lotions for antipruritic and cooling effect, and widely used in proprietary chilblain preparations. Honey, used since ancient time for dressing wounds, particularly decubitus ulcers, venous ulcers, and surgical wounds. Honey inhibits bacterial growth. Methanol is added to calamine and other lotion or creams to induce cooling sensations and relieve pruritus. Thymol is a traditional and potent antibacterial and antifungal agents, most often used as 4% solution in chloroform or absolute alcohol. It is used for paronychia and fungal lane infection. It should be applied for 2 to 3 times a day. Then certain miscellaneous agents. Bicaplermin, a gel containing bicaplermin 0.01%, known to accelerate healing of deep decubitus ulcers when applied on a wound for 12 hours. Pressure ulcers also seem to respond. The cytokine promote the growth of pre-existing malignancy. Bimetaprost is a prostaglandin analog and agonist of prostamide alpha F2 receptor. Initially used for treatment of glaucoma, subsequently used in USA for cosmetic treatment to stimulate eyelash growth. Trials are ongoing to investigate the clinical value of the compound in androgenetic alopecia. So this is a promising compound. Bromonidine is an alpha-2 adrenergic antagonist that causes cutaneous vasoconstriction. Bromonidine gel is used to develop the treatment of flushing and rosacea. Onset of effect is rapid within 30 minutes and duration of action lasts for 12 hours. We do not have the bromonidine gel, but we have this preparation available as eye drops. That is the alpha-gon eye drops. So we use the alpha-gon eye drops for all the indications in which bromonidine gel is used. Then caffeine is a phosphodiesterase inhibitor with potent anti-inflammatory activity. A 30% caffeine cream is used for treatment of atopic eczema and is claimed to have marked antipruritic effect. There is improvement in psoriasis treated with 10% caffeine in an emollient. It has been shown to enhance UVB-induced apoptosis and inhibit UVB-induced carcinogenesis. Also found to increase the rate of hair growth, and shampoo and hair tonics have been developed to incorporate the caffeine in it. So caffeine is again a new prospect in treatment in various topical hair stimulating products. Capsaicin. It is extracted from hot peppers and responsible for gustatory discomfort they induce. Capsaicin stimulate the release of substance P, which is subsequently depleted in sensory neurons. Stimulation of this receptor by capsaicin results in hypoalgesia. This is used topically in treatment of post-herpetic neuralgia and finding its way in diabetic neuropathy, glossodynia, nodular prurigo, notalgia paresthetica, pruritus ani, puva itch, and uremic pruritus. Chromoglycates. Sodium chromoglycate is a safe compound that inhibits the release of inflammatory mediators from mast cells and used topically in treatment of asthma, rhinitis, and conjunctivitis, and orally for food allergies. It is the subject of several trials for topical treatment of atopic eczema. 4% lotion have yielded convincing evidence of modest effect and also a steroid sparing action. Dihydroxyacetone, DHA, reacts with amino acid in stratum corneum to form a brown pigmentation. This reaction is based on large industry that resolves, inducing false tanning. DHA is constituent of a vast array of proprietary cosmetic products, cream, lotions, and sprays used to mimic a suntan. Some sufferers from vitiligo find the use of DHA helpful as cosmetic camouflage. Indomethacin. With the exception of diclofenac, non-steroidal agents have found little use in dermatology. However, topical indomethacin have been used potentially to reduce erythema after application of liquid nitrogen in normal skin. Ditronol or anthralin is a time-honored topical treatment of psoriasis. It is used in ointment, paste, and creams, as pomade, and used in scalp. It inhibits glycolytic enzymes in vitro. Reactive oxygen species are generated that inhibit mitochondrial functions. Ditronol has marked anti-proliferative effect with remarkable safety, although staining of skin, clothing, and baths is a drawback. There is no evidence of any systemic toxicity. Combination of salicylic acid and tar with ditronol is said to reduce ditronol irritancy and enhance its therapeutic effect. The use of water-soluble antioxidant ascorbic acid has allowed the production of stable ditronol cream preparations. Short contact application of strong ditronol paste or cream are known to almost as effective as prolonged contact use and facilitate treatment on an outdoor basis and self-treatment at home. Ditronol has been used to stimulate an inflammatory response and regrowth of hair in patients of alopecia areata, and also used in treatment of viral warts. Glyceritic acid. This compound has anti-inflammatory properties and incorporated in topical preparations for atopic eczema. Minoxidil. This vasodilating agent was initially introduced as systemic treatment for hypertensive and was found to cause hypertrichosis. Hence, lotions containing 2% and 5% minoxidils have been used in hair thinning since many years. Minoxidil can also accelerate hair regrowth after chemotherapy, and there is possibly some modest effect in patients of alopecia areata. Morphine. Alleviation of pain by using varied formulations of topically applied morphine is reported in range of indications like pressure ulcers, sickle cell ulcers, and ulcerated scleroderma. Clearly, topical administration is a mean of avoiding or reducing central nervous system side effects. Nicotinamide or nicotinic acid. It has a marked anti-inflammatory properties and used in topical treatment of acne vulgaris. A 4% alcoholic gel is available. Topical application of nicotinic acid has the ability to induce vasodilation and can produce a warming and soothing remedy of soft tissue injuries. Nitrite, nitric oxide, or glyceryl trinitrate. Nitric oxide is a short-lived gaseous free radical, plays a pivotal role in physiological role in regulation of vascular smooth muscle contraction. Vasodilation induced by the application of acidified nitrate may prove beneficial in promoting the survival of surgical flaps. Glyceryl trinitrate or GTN is another source of nitrous oxide, 0.1 to 0.4% ointment increase the blood flow in patients with Raynaud's disease, in perniosis and scleroderma. GTN is also used for anal fissure. Salbutamol is a beta-2 adrenoreceptor agonist, a potential as topical immunosuppressant and anti-inflammatory agent. Useful in discoid and subacute lupus erythematosus as 0.5% salbutamol cream. Silicone. Range of silicone gels and sheet dressings are marketed for prevention and treatment of hypertrophic and keloidal scars. The most likely mechanism of action of occlusion on keratinocyte hydration, which could alter the epidermal cytokine signaling directed to dermal fibroblasts. So this comes to the end of this topic, that is the topical formulations which are used in dermatology. Although it was a long lecture, but I hope that after going through this lecture, you will be more educated and more equipped and will be having a better understanding of use of various topical formulations in different indications of cosmetic and clinical dermatology. I thank you all for a very patient listening. Goodbye and have a very good day.